Okay, so today on Road to 250, I'm going to talk about lymphomas, EBV as our bug, and then like an overview of anti-cancer drugs in terms of their category and how to kind of categorize them and make associations in that sense. So to start off with, lymphomas. So for lymphomas, initially what is diagnostic or how to kind of pick out this pathology is that we have a node at suspicion or at a suspicious site. So an enlarged node at places that are significant for cancer. And so most importantly, these are going to be the supraclavicular node, inguinal nodes, and epitrochlear nodes. So supraclavicular around the clavicle, inguinals are the inguinal area location, and then the epitrochlear is like your elbow location. So like the pathology says, lymphomas is a malignancy of your lymph nodes. So when you have this, what's important to do to really differentiate what exactly is going on pathologically is that we need to biopsy it ASAP. The way you want to differentiate these is you have an enlarged lymph node, we're going to biopsy it. What we're looking for on biopsy is whether it is positive or negative for Reed-Sternberg cells. So if our biopsy shows positive Reed-Sternberg cells, then we can indicate this as Hodgkin's lymphoma. If we have no Reed-Sternberg cells seen on biopsy, it's going to be a non-Hodgkin's lymphoma. Okay. So just in general, to give us a little bit of overview about leukemias versus lymphomas, leukemias are going to be our neoplasms of the bone marrow. Lymphomas are going to be neoplasms of lymphoid tissues. However, lymphomas can end up in the bone marrow, and leukemias can be seen in the lymph nodes, hence why you see the mixed match and confusion and how that kind of occurs. So now in terms of Hodgkin's versus non-Hodgkin's. So Hodgkin's is, like I said, we're going to see Reed-Sternberg cells, which are these owl eye cells, which I'm going to talk about a little bit in a little bit. They are, so Hodgkin's is generally going to be a single group of lymph nodes with contiguous spread. 50% of it is, or 50% of these patients do have association with EBV infection. And this random fact, I guess, 10% have also been known to be associated, or 10% of the patients will indicate an association with pain when drinking alcohol. So that's something. But more characteristic on that note is that it affects patients in a bimodal distribution, meaning mostly it's going to be seen in young ages or older ages. So young adulthood or greater than 55 years old. And it is more commonly seen in men, except for the nodular sclerosing type, in which the male to female ratio is more equivalent. So non-Hodgkin's lymphoma, this is going to be multiple lymph node involvement, and it's going to be a non-contiguous spread. So for example, you can have a patient who has involvement of lymph nodes from the axillary region, the inguinal region, and the cervical region, and they're all infected or affected simultaneously. Non-Hodgkin's lymphoma is associated with HIV infection and autoimmune diseases. It does have a poor prognosis, and something that is common between both Hodgkin's and non-Hodgkin's lymphoma is that these patients constitute a something called B signs or B symptoms, which is going to be low-grade fever, night sweats, and weight loss. So that is quite characteristic of patients in general when you are differentiated, for example, from leukemias and lymphomas. Okay, so Reed-Sternberg cells. Reed-Sternberg cells, like I said, the presence of them indicate are pathognomonic for Hodgkin's disease. And if they are absent, we're dealing with non-Hodgkin's lymphoma. They are these owl-eye appearing cells, and they can be identified by CD markers 30 and 15 on flow cytometry. So owl-eye, it appears as two eyes. And I guess fun fact, or I guess a pin question, do you know what other cells on microscopy can also be known or characteristically identified as owl eyes?
Giardia?
Yes, and? CMV. So the one on the left, I guess, yeah, everyone's left, hopefully, is Giardia, and my right is CMV. So, yeah. And then real quickly here, the bilobe nucleus here is what is the Reed-Sternberg cell. Okay, so to break down Hodgkin's lymphoma, it has good prognosis, again, enlarged lymph nodes, and there are 4 types: nodular sclerosing, lymphocyte predominant, lymphocyte depleted, and mixed cellularity. First aid doesn't really go into detail of these subcategories, besides kind of letting us know that nodular sclerosis is the most common, lymphocyte rich has the best prognosis, mixed cellularity is characteristically seen where you see eosinophilia, and lymphocyte depleted is going to be most commonly seen in immunocompromised patients. So to just kind of go in one step in more, nodular sclerosing is the most common type. It is seen more in females than males. It has the least number of Reed-Sternberg cells. It has intermediate prognosis. It does have, I think, lots of scarring on lymph nodes, and seen commonly in adolescents and or greater than 50 years, so the bimodal distribution. The lymphocyte predominant is rare. You see many lymphocytes, and it has the best prognosis of all subtypes. The lymphocyte depleted, it has the least number of lymphocytes, hence depleted, has the worst prognosis. It is rare, and it is commonly seen in HIV patients. And then last is the mixed cellularity type. You see many Reed-Sternberg cells that's mixed with many inflammatory cells like lymphocytes, histiocytes, eosinophils. It is associated with EBV, so there's that. And then has intermediate prognosis. It is common, contains the most Reed-Sternberg cells of all 4 subtypes, and is also seen in HIV patients. As I said earlier, it's most commonly seen in patients who are immunocompromised, and it can present with either abdominal mass or jaw mass. Commonly seen in patients who are American or in America, living in America, so abdominal or pelvic mass, versus the jaw mass is more commonly associated with patients who are from developing countries. So I'm going to kind of talk about follicular lymphoma and Burkitt's lymphoma like in a little more, slightly more detail than the rest, which there are more. And I guess I kind of put these as maybe they're the most highly tested or high yield, but I'm going to talk about all of them. Okay, so follicular lymphoma. It presents with a painless lymph node enlargement or abdominal discomfort from an abdominal mass. So follicular B cell, so it's a B cell tumor, which I'm going to show the differentiation as well in a second. It is associated with a translocation 14/18. And as a result of this translocation, it causes overexpression of the anti-apoptotic gene product BCL2. And you can remember anti-apoptotic, so it wants the cell to live, and BCL2 has 4 letters that can indicate live, LIVE, 4 letters to help you remember. And as a result of this overexpression, there's formation of tumors. So it is characterized mainly by centrocytes. These are small cleaved cells, and a small number of centroblasts, which are large non-cleaved cells. So that could be another clue for you. The course is indolent, meaning it's slow progressing and waxing and waning. It has that characteristic, and it's marked by remissions and reoccurrences, so waxing and waning. And the average survival from time of diagnosis is about 10 years, so slowly progressive. On the other hand, Burkitt's lymphoma is a translocation between 8-14, and this translocation of the c-Myc oncogene on the long arm of chromosome 8 results in the Ig heavy chain region on so it translocates with the Ig heavy chain region on chromosome 14 that produces a nuclear phosphoprotein. So that's c-Myc. And that functions the function of that is transcription activation. So that is what your mutation is causing. And there is association with EBV, as we know, and on histology, what's quite characteristic is that we see a starry sky appearance. So the starry sky appearance is essentially this purple background that we see, and the purple background is staining heavily because there's hundreds of cancerous lymphocytes. And it's we see a lot of an extreme rate of lymphocytes because there's a high turnover rate and a lot of apoptotic debris left over, which is what the purple background is. And then, so that's, And then c-Myc is again, transcription factor that upregulates cell division. So hence why we see lots of apoptosis occurring, anti-apoptosis. So I'm confusing myself. High turnover rate, and so you see apoptotic debris. Okay, so like I was saying, non-Hodgkin's lymphomas can be broken down into also 2 subcategories, which is mature B-cell neoplasms and then mature T-cell neoplasms. So what I currently just talked about with Burkitt's and follicular lymphoma, they fall under the mature B-cell type. And so it falls under the mature B-cell type. So to continue on, I've already talked about Burkitt's and follicular. So the diffuse large B-cell lymphoma type, it's known as the most common type of non-Hodgkin's lymphoma in adults, and but that does not subject it to not occur in children. So 20% is still seen in children. And like I said, there's an alteration in BCL2 and BCL6 genes. And remember, what does BCL2? What is its role or purpose again? It is
anti-apoptotic.
Exactly, it's anti-apoptotic. So when it becomes upregulated, the cell basically becomes immortal. And an impaired BCL6 gene will cause premature inactivation in B cells. Mantle cell lymphoma. This is a translocation between 11-14. And it causes an overexpression of cyclin D1, which is involved in the progression from G1 to S phase in cell replication. And this overexpression then causes unchecked regulation to occur. And so it becomes a very aggressive lymphoma. And patients typically present at the late stage in the disease. The marginal zone lymphoma, this is a translocation between chromosomes 11 and 18. There is chronic inflammation seen in these patients, for example, like Sjögren's and chronic gastritis. So that's going to be found in the GI tract. So the multiple lymphoma is going to be our association with the marginal zone lymphoma. And then last, primary cell nervous system lymphoma. This is commonly associated with HIV and AIDS. It is an AIDS-defining illness. And it's usually diagnosed with a mass lesion on MRI. And it presents similarly to toxoplasmosis virus. And so, and so it's important to maybe do a CSF analysis to differentiate the two there. Yeah, so those are our B-cell neoplasms. The neoplasms of mature T cells, so the adult T-cell lymphoma, it's caused by human lymphotrophic virus, and it is associated with IV drug abuse. And so adults present with cutaneous lesions, commonly seen in Japan, West Africa, and the Caribbean. And then on labs, you see lytic bone lesion and hypercalcemia on examination, I guess, more so. And then mycosis fungoides, progression from cutaneous T-cell lymphoma to a T-cell leukemia is what is known as Sézary syndrome. And the symptoms of these patients is going to be cutaneous patches and plaques that can then spread into the lymph nodes and viscera. And as a result, they get a intraepidermal neoplastic cell that aggregates known as premature microabscesses. And so that kind of pretty much sums up mycosis fungoides / Sézary syndrome. It is characterized by atypical CD4 cells, so that's important to make a note of. So that sums up the concept, lymphomas. Any questions or anything anybody wants to add? All right. So then I will move on to the bug, and in association with lymphomas, it's going to be EBV. Can someone or anyone tell me what the genetic material makeup of EBV is, or perhaps just the class of virus?
Envelope DNA linear.
Yeah, it is. Yeah, linear. Yep, linear envelope. Exactly. Yep. So EBV contains double-stranded linear. It is an envelope genetic material. It is known as a herpes virus. And does anybody know which type? What number type? So it's type 4. And so what is the common characteristic or illness do we know that EBV causes?
Mono.
Yeah, exactly. Yeah, so mononucleosis. And along with the fever, hepatosplenomegaly that you see pharyngitis. So patients will describe symptoms of hurting when they swallow. And lymphadenopathy. So the infectious process for EBV is essentially is transmitted by respiratory or saliva secretions, and you see the lymphadenopathy, especially in the posterior cervical nodes, but it doesn't mean that you might not also see just generalized lymphadenopathy in these patients. And the infectious process specifically is that EBV infects the B cells, causing this increase in hepatomegaly and splenomegaly via the glycoprotein via the glycoprotein receptor of EBV, which will latch on through the CD21. And so that process of attaching to CD21 through the glycoprotein of EBV will cause infection of B cells. And what is a test that we can use for? Yeah, exactly. So this for diagnostic features is a positive monospot test, also known as heterophile test. And essentially, heterophile antibodies are detected by a agglutination of sheep or horse RBC in the test. We do use amoxicillin in mononucleosis. Using amoxicillin in these patients who have mononucleosis can cause a maculopapular rash, which is also commonly seen. And then last but not least, it is associated with lymphomas, especially endemic Burkitt's lymphoma, nasopharyngeal carcinoma, which is seen more in the Asian adult population, and then lymphoproliferative disease in transplant patients. So, what is another virus that we commonly see in transplant patients?
CMV.
Yeah, CMV is the one I was going for. Yep. So, any questions or anything that anybody wants to add about EBV? Okay. So the drugs is just going to kind of be, like I said, categorically subcategorizing how our anti-cancer drugs are broken down and how they're essentially engineered. So we have the G1 to S to G2 to M phase progression. In G1, so predominantly in the G1 phase, its role is to make proteins that are going to be required for replication. So makes lots of proteins for DNA replication, like like helicase, primase, DNA polymerase 1, DNA polymerase 3, ligase, topoisomerase. Those are going to be what's going to be made protein-wise in the G1 phase. So everything pretty much except for centrioles. In the G1 to S phase transition, obviously there is a checkpoint here. In S phase, this is going to be DNA synthesis, like we see, and formation of centrioles, which are going to become important later in the cell cycle. And that's where DNA synthesis occurs and replication occurs. So, The G2 phase is important in making proteins specific for mitosis. And then mitosis is, our M phase is going to be mitosis itself, so replication. And then the G0 phase is just our resting phase, as we know. Okay, so in general, the G1 phase then can be inhibited by anti-cancer drugs that are cell cycle independent drugs. And so does anybody know what type of drugs that would be?
I only know busulfan is in that category.
Alkylating agents?
Yeah. So yes and yes to both of you guys. So the category or subcategory of the subcategory is going to be alkylating agents and platinum agents. So that's going to be our cisplatin. And then what make up the alkylating agents, as Yash said, busulfan, cyclophosphamide, ifosfamide, and nitrous ureas, for example, carmustine. Then we have drugs that inhibit DNA synthesis. These are known as the anti-metabolites. Does anybody name any of these? There's quite a few of them.
5-FU, 6-MP.
Yeah, exactly. So these are going to be, like you said, 5-FU, 6-MP, methotrexate, hydroxyurea, cytarabine, also known as Aracy, cladribine, and azathioprine. Then we have drugs that are going to work between the S and G2 phase, known as the topoisomerase inhibitors. Can anybody name any of these?
Etoposide.
Yeah, I can kind of see it. But etoposide, topotecan, irinotecan, tenecoside. Then there's only one drug that will inhibit the G2 phase. Does anybody know it?
Bleomycin.
Exactly, bleomycin. And then our M phase inhibitors are microtubule inhibitors. And can anybody name any of these?
Vinblastine, vincristine.
Yeah. Yep, so paclitaxel and the vinca alkaloids, vinblastine, vincristine, and then pyributylene, I guess, got added on there. So, yeah, that's all I got in terms of drugs. Anybody want to add anything or have any questions? Okay, so I have some questions for you guys then. So here I have a 16-year-old girl visits her physician for a routine checkup. She reports increased tiredness while at school for the past 3 weeks, but otherwise feels fine. On physical examination, her temperature is 100.4, blood pressure is 112/78, pulse is 88, and respiratory rate is 16. She has mild pharyngitis on inspection of the oropharynx, and tender axillary lymphadenopathy is also noted. Her spleen is palpable, and her liver feels mildly enlarged on abdominal examination. A complete blood count shows the following. Hemoglobin is 13, hematocrit's 41, mean corpuscular volume is 88, platelet count is 300,000, and white blood count is 9,000. A rapid streptococcus test is negative. However, reactive heterophile antibodies that agglutinate horse red blood cells are found in the patient's serum. Peripheral blood smear is performed, and an image of the smear is shown, which I did not show. So, the virus that causes the infection described above is associated with what other disease? A, acute glomerulonephritis, B, cervical carcinoma, C, malt lymphoma, D, nasopharyngeal carcinoma, E, rheumatic heart disease.
D.
All right, D for dog. So, yeah, this patient has EBV, and it can also cause nasopharyngeal carcinoma. All right, so here we have a 28-year-old previously healthy man comes to the office due to episodic fever, night sweats, and weight loss for several months. He immigrated from Kenya with his family at age 14. He does not use tobacco, alcohol, or illicit drugs. The patient works as a driving instructor and volunteers at a homeless shelter. His temp is 99. Physical examination is normal with the exception of cervical lymphadenopathy. A lymph node biopsy is performed, and a histopathological slide is shown in the image below. I will show you that in a second. There it is. And so, which of the following is the most likely diagnosis? A, Burkitt's lymphoma, B, follicular lymphoma, C, Hodgkin's lymphoma, D, large B-cell lymphoma, E, multiple myeloma, F, tuberculosis.
C.
B.
I have A, I have B. Anyone else?
I said C, not A.
Oh, sorry, C. Okay, C and A. Is that what it is? Okay, so... it's C, Hodgkin's lymphoma, because one, the histological slide then would have been like a starry sky appearance, and two, he has the B symptoms, though, yeah, he immigrated from Kenya. It's not, I think, pretty much essentially the histo slide is supposed to indicate just read Sternberg cells and not a starry sky appearance. And he just has, so he has the cervical lymphadenopathy, but yeah, pretty much that's kind of what's going to give off why it's Hodgkin's and not Burkitt's. Make sense? Okay, last one. A 23-year-old man from Kenya comes to the primary care physician with symptoms of night sweats, fevers, reduced appetite, and decreased urination. His past medical history is significant for asthma. On physical examination, the physician notes a large non-tender mass underneath his mandible. Abdominal exam reveals a non-tender distended abdomen with no hepatosplenomegaly. A biopsy of the submandibular mass shows an aggressive tumor with sheets of lymphocytes staining positive for CD20, as well as very high levels of nuclear c-MYC with interspersed macrophages. What is the genetic makeup of the causal organism?
B.
Anyone else?
It's B.
Uh,
I said B. I don't know if you heard that.
okay, and Divya said B.
Mm-hmm.
I think it's C. Is that right? It's. Oh wait, hold on.
Is it EBV?
Yeah. Darn it, I don't have it here. That might be wrong. Okay, I'm going to check. It is double-stranded and linear, so actually B, B would be right.
It's a herpes virus, right?
Mm-hmm.
Yes, it is. So, yeah, sorry guys, have the wrong answer. Yeah, double-stranded, linear. So, yes, it should be B and not C. So, scratch that, should be B for boy. And that's all I got.